there?
Yeah, I'm
Because I
here.
can't
Hi.
see. I can't see the video.
I'm here. Hi. It was It was off. Yeah.
Okay, so I'll just go on to the brief introduction of Dr. Rao. Dr. Srinivas Rao is from Chennai. He's been undergone training in Boston. There are a lot of surgeons, big surgeons here, trained abroad. I feel slightly small. He's been trained in phacoemulsification in Canada and LASIK in Minneapolis. He's lamellar corneal surgical training in Rotterdam. I think there's no country left. He's certified for advanced IOL surgery and alpha core prosthesis and has been trained in epidemiology and biostatistics. Wow, at Estelle Donny, California. Attended 100 and more than 150 national conferences and more than 40 international conferences. Over more than humongous 300 lectures, published 182 papers in peer-reviewed journals, and authored more than 20 books. Reviewer for 10 peer-reviewed journals, anterior segment section editor, and he's got outstanding service and prevention of blindness and APAO, and also an oration award in 2006, Rustam Ranji Oration Gold Medal. So I think that's a large list. Over to Dr. Rao, and I was not interacting with Dr. Rao earlier because I couldn't see him on screen. I was wondering whether he's gone there or not. Dr. Rao, over to you for your topic.
Yeah. Thank you, Dr. Kapoor. Can you see my slides now?
Yes, very clear.
Okay. Thank you. This is a fairly important topic that's been gaining precedence in the recent years. And for those of you who are interested in reading more about this, basically, there was one entire issue of the IOVS in 2011, which was dedicated to various aspects of Meibomian gland disease. And I'd like to acknowledge that some of the pictures that I'll be using during the talk are from that journal, because I find that they're the most representative of what I would like to say. So for those of you who are interested in understanding a little bit more about Meibomian gland dysfunction and its management, this would be a good resource for you. So in order to understand Meibomian gland function, only then can we then go on to managing its dysfunction. We need to look at the anatomy of these glands. There are about approximately 25 to 30 glands arrayed in each lid. They are placed vertically and they open on the lid margins, and we know that. They produce basically a complex mixture of protein and lipids, and there is basically a predominance of unsaturated long chain fatty acids in the natural secretions that they make. And this is important because the eye tolerates these products very well, and when the composition changes, we can have problems. The function of the Meibomian glands and the oil that they produce is to decrease the evaporation of the aqueous layer of the tear films, so that between the two blinks that we heard Dr. Mehta talk about, the tear film remains intact. If you do not have the protective oil between one blink and the other, there's a rapid evaporation of the very thin film that you have, and then you can have problems. The oil also helps you preserve a clear optical surface, and it forms a barrier to protect the eye. So this is as far as the gland function. So we then need to understand what happens when there is dysfunction to these three elements. So if you look at the anatomy, there are various conditions, disease conditions that can cause a destruction and atrophy of these glands. And this picture here of the lower lid of one eye of a girl shows a congenital maldevelopment and absence of the Meibomian glands. There is just one distorted gland present in the lower eyelid. And in this context, if there is very little oil that is being produced, obviously the tear film will suffer. In disease, basically the long chain fatty acids that are present get broken down when there is excessive bacterial colonization of the lids. The bacteria use the oil as an energy source. So they then break them down into short chain fatty acids. And this change in composition, the eye does not like. The surface finds it very irritating because these short chain fatty acids and triglycerides cause a lot of inflammation and irritation on the ocular surface. And obviously, when you do not have enough oil or when you have excess oil as well, the oil contaminates the ocular surface, and then the breakup time will suffer. And then you can do as kind of an NIBUT, and it shows you that the breakup time is very short, and this will have its own implications. So in order to assess this dysfunction, it's quite simple to look at the normal anatomy by just flipping the eyelid and looking at the palpebral surface of the lid. You will be able to appreciate these little yellow worm-like structures that are present, which are actually the Meibomian glands. But if you have access to a Meibographer, an infrared device which images this, then you can look at this in far greater detail, as you can see in the lower picture on that slide. And this will help you assess the number of glands that are present, the structure of these glands, and to some extent the function as well. When you want to look at the physiology of these glands, which is basically the secretion that it produces, this is a spring-loaded pressure device, which is devised by Cobb and Blackie. So this produces a graded amount of pressure on the middle of the lower eyelid, and then you can assess the number of glands that are actually expressing the oil, the amount of oil that is coming out, and the quality of the oil that is being expressed. But you can do this just as well with your thumb. You can just put your thumb and put gentle pressure over the lower eyelid. Normally, you encompass between 4 and 5 gland openings with the thumb, and then you can see how many of them are expressing oil, how much of oil, and what is the quality of the oil. Now, the other aspect of the function is the protective film that it forms on the surface, and in order to do this, you need an interferometer. So this will tell you the quality of the oil on the tear film and also the thickness of the oil on the tear film, and this is quite important, as we shall see in other for various functions on the surface. This is clinically very difficult to reproduce, unlike the pressure test, which you could just do for the physiology. But if you have a lot of oil on the surface, sometimes you can see these interference fringes, these rainbow-colored hues on the tear film, and that tells you that there's a lot of oil on the surface, but this is not a very reproducible test. Now, when we have the secretions that the glands make, so in the upper picture, you see that when you put pressure on the lower eyelid, normally you will see a small bead of clear fluid that comes out from the gland opening, and this is how it normally works. But in Meibomian seborrhea, as in the lower eyelid, when you put pressure, you may see actually a gushing of a clear fluid, an excess amount of fluid, and this is called Meibomian seborrhea. If you put pressure on the lid and you see this kind of Colgate toothpaste kind of stuff actually squeezing out in little worm-like ridges, this is basically an inflammatory change in the glands, and this kind of inspissated material we term meibomitis, where there's a lot of inflammation, and each of these has different implications. And the third variety is when you see these glands which have shrunk down to pinpoint openings, and when you look at the lid itself on the inside, you can see hardly any glandular structure. So here, for some reason, disease has resulted in destruction and atrophy of the glands and cicatrization of the openings. And here, no matter how hard you push, there will be no oil that comes on from the surface, and this is called Meibomian sicca. So these are the various types of dysfunction that can occur as far as the secretions are concerned, and this has important implications in the management as well. So typically, when you have Meibomian gland dysfunction, the lids will also undergo dysfunction. And as you can see in this cartoon on the left, there's an inflamed lid, and on the right, it's normal. And this is how an inflamed lid will look. It will be thickened. You will see a lot of vascular dilatation on the lid margin. And you may see these kind of Meibomian gland oil capping the various openings of the glands. And the posterior lid margin may be rounded as well. And sometimes you will see this kind of a froth. This is because when you keep blinking and agitating the oil, due to the change in the quality of the oil, it froths up like this. So this kind of froth on the lid margin is typical of Meibomian gland dysfunction. So this is the posterior lid margin where the Meibomian glands are. They are often associated with anterior lid margin changes like seborrheic blepharitis and staphylococcal blepharitis. And we call it the triple S syndrome. Usually when there is seborrhea, there is also sicca and staphylococcus, and these three tend to work hand in hand. So these are the changes during dysfunction. So what exactly does it imply as far as we are concerned? You can also have Meibomian plus disease, Meibomian gland plus disease. These are due to the changes that actually happen in the gland. So because of the excess oil production and the infection that tends to set in, you can get chalasia, you can get corneal changes when these inflammatory products come onto the ocular surface. You can see the conjunctival inflammation, you can see the inferior corneal infiltrates. These changes, which are typical of staphylococcal immune keratitis, are typically seen in the inferior cornea because they are in closer proximity to the lid and the tear meniscus, which contains all of the toxic substances from these inflamed glands. And you can see these kind of sleeves, the cylindrical sleeves on the lashes. And this is suggestive of Demodex blepharitis, which can also occur in conjunction with Meibomian gland disease. So when you have seborrhea, when you have excess oil coming onto the surface, it tends to break through the tear film and contaminates the corneal epithelium, making it a hydrophobic surface, which it cannot retain the water. And then you get the short BUT type of dry eye. So these people will have a normal Schirmer. They may not have much fluorescein staining of the corneal surface, but if you take the time to look at the BUT like Dr. Himanshu showed, you'll find it's very short, and these people will complain of a lot of irritation on the ocular surface and blurred or fluctuating vision because of the poor quality of the tear film. When you have a sicca, when you don't have enough oil protecting the tear film evaporates, and between blinks, it is no longer present. It is no longer protecting the corneal surface. The corneal surface effectively dries, and over the course of time, there is epithelial damage and death, which is typified by this type of typical staining with fluorescein, which we term superficial punctate keratitis. And in the meibomitis or the inflammatory variety, when you have a lot of inflammation in the oil, which is then coming onto the surface, you can either get conjunctival flictanule, as you can see on the left, or if it goes on to the cornea and you don't manage it adequately, a lot of collagenases are produced from the inflammatory mediators, and you can even have an inferior corneal perforation from the lid margin changes. Therefore, when we talk about the treatment, we don't really have one treatment, one magic bullet that treats everything. We have treatment principles which are guided by the quantum of oil that is being produced, the quality of the oil that the lids are producing, and the inflammation that is associated with these changes. And essentially, what we are managing is this. So, therefore, if we understand these principles, we will be able to manage the meibomian gland dysfunction as a whole. So when you have excess of oil being produced by the lids, we need to control that and reduce the quantum. We need to squeeze all of this excess oil out of the lids. We typically do this by first using warm compresses. This is to melt the oil really. The oil gets very thick and doesn't come out easily. So the warm compresses help liquefy the oil. Then you do a lid margin scrub with a moistened cotton bud, because many of these gland openings in these inflamed lids are caked shut with these secretions. So you need to break those off before the oil can come out. And then we physically massage by trapping the lid between your finger and the globe, above downwards for the upper eyelid and below upwards for the lower eyelid. And this manual method works quite well. But typically, the patient has to spend about 15 minutes every night, and he has to do this for an average for about 3 weeks to get the relief that is required. And therefore, for those people who can't be bothered to do this and who don't mind spending a bit of money, we have mechanized devices like the Lippy Flow, where the warming of the lid and the massage is done in one session where you just sit like a spa and then it's done. And then you can get benefits ranging for between 6 months to a year with this. It's a little expensive, but for those people who don't want to sit at home and do all this massaging and scrubbing and so on, this is an option that you have. If you have less oil because of the sicca, various methods have been tried to open up the glands. Something that's been advocated and is being done a lot in the West, in the US, is the probing, and this is the Masket probe. So these are just basically thin stainless steel wires which are inserted through these closed openings and passed into the gland, just like you would dilate a lacrimal canalicular system. And you're hoping that after you do this, the glands will be able to excrete the oil on the surface. And sometimes in people with severe conditions like ectodermal dysplasia, everything is just squeezed shut inside, so nothing can come out. So typically once a year, you can take these children to the OR and under GA, or if they will tolerate it under LA, you have to physically squeeze all this infiltrated stuff out. And then you hope that after this, you can modify the gland behavior, which I will share with you in the next slide, to produce a better quality of oil in these. And these are the manual methods. We heard Dr. Himanshu say that when the lid blinks, that is when the oil gets squeezed out onto the surface. And in some people with very lax lids, like in the floppy eyelid syndrome, you can even consider in desperate situations surgery, which has been suggested to tighten the lids and reduce the horizontal laxity, so that when these lids blink, they can now function to pump the oil out onto the surface. Now, this is about the quantity of the oil if you have excess or minimal oil. The next important thing is the quality of the oil, because the oil changes in meibomian gland dysfunction due to the bacterial co-infection of various other causes. And we can traditionally treat it medically by using azithromycin ointments. Azithromycin has a role on this. You can use oral doxycycline on other macrolides like tetracycline or erythromycin or azithromycin or orally as well. And these are done not so much so to reduce the bacterial effect, but to modify the quality of the oil that is being produced in the meibomian glands. And despite the recent DREAM study, I still think that the omega-3 fatty acids help in the more severe kinds of these, and I do use them in the more severe versions of meibomian gland dysfunction. And so this is as far as the medical therapy is concerned. Recently, we have the pulse light that can be used, and this is called the IRPL, or the intense regulated pulse light therapy. So what is basically believed here is that when you apply the light to the periocular regions, basically there is a stimulation of the deep nerves that goes on. And when this happens, these nerves then are able to modulate the function of the meibomian glands better. Now, this is derived from its use for acne, rosacea, and dermatology, where it seems to work well. And this is a serendipitous effect that has now been developed. And the IRPL treatment works quite well. Now, this is not to be confused with the Lippy Flow. The LipiFlow is a device that is used to express the excess oil out, whereas the IRPL is used to basically modify the quality of the oil, and you'll have to do some kind of physical expression to get rid of the excess oil as well. So these are two complementary technologies. They don't necessarily have to work independent of each other, and sometimes they may even work by combining with each other. And the IRPL that we have been using for the past, I think, 6 months now seems to work well, particularly in patients who fail medical therapy. And this is a good addition to our armamentarium for managing this condition. So for the inflammation part of the meibomian gland dysfunction, we use topical steroids, we use tear substitutes to keep the surface flushed and clean, and we use cyclosporine A in the chronic situation. And this is how it starts. Initially, you will see the inferior corneal peripheral vascularization. If you don't treat it at this stage, it goes on to these flictanules of staph immune infiltrates on the cornea, which migrate gradually towards the center. And if you still don't manage them, the infiltrates can actually perforate. But if you catch them even at this stage and treat them with the lid hygiene and with the steroids and tear substitutes to reduce the inflammation, everything quietens down. And by continuing to maintain the lid, you can keep this from recurring as well. For Meibomian plus disease, basically you can also now use intralesional steroid injections into these chalasia if they are recurrent, rather than cutting up the lid multiple times. This can be done with some lignocaine jelly on the surface and just inject a dilute or 50% dilution of triamcinolone 10 milligram per mil. You have to inject it with a little pressure. Part of the way it works is by increasing the hydrostatic pressure inside the chalazion and causing micro breaks in the wall. And then the anti-inflammatory effect of the steroid helps the body come in and cut away the material that's inside the lid. If you have the associated Demodex, you can use some of these herbal anti-dandruff shampoos, which contain about 5% of tea tree oil. So you do a scrub of the lid margin for about 4 or 5 minutes, and you can wash it off after that. And this scrub allows the tea tree oil containing medication to go into the meibomian. And this keratin seen in desperate diseases, typically like advanced Stevens-Johnson and OC, even not going to manage that. But they will also be associated with meibomian gland dysfunction. One of the things that we have available now is topical vitamin A ointment, which can be used to treat this kind of dysplastic change of the lid margin. Basically, meibomian gland dysfunction is a very common entity in Asian eyes. It comes in various forms. It is to recognize the different types, like I tried to share with you. Because if you can understand the pathophysiology, then you can work up a nice treatment regime, which is partly medical. And now with the newer procedures that we have, like ARPF, you can use those to modify the gland dysfunction. Thank you very much.
I think Dr. Rao, that was a class, actually a master class in meibomian gland problems. And I guess, as we all know, that meibomian glands is probably one of the leading causes of why patients are presenting to us in our OPDs, and most of them are dry eye patients. And I, a lot of times, would like to add something here. Patients with a borderline MGD, post cataract surgery, is going to be one of the most unhappy post cataract surgery patients. Now, what I've seen, we have a dry eye unit and a dry eye vertical in my organization, with being taken care by me and my cornea people. One thing it has done for the audience, they must understand. I get patients from operated from fellow colleagues, fellow other clinics, 6/6 surgery probably better than me, but the patient's only complaint of, after surgery, I'm not happy. There is some problem. There is some irritation. I feel there is a foreign body in my eye. And once they come to us and we take them up for dry eye management and give whatever relevant therapies required, guess what? They get their second eye done from us. And the poor earlier surgeon who had no contribution to the ailment of the patient, but in the patient's mind, it was problem created by the cataract surgery. And the end result is, so everybody needs to be well informed and aware of, dry eye as a diseased entity and its management. Dr. Rohit, I'd just like to bring you in again on this issue of meibomitis and MGD. Anything else you would like to add? There's so many things available with, cyclosporins and chloroquine and azithromycin. There's a gamut of things, and I don't think there's any other better person than you to, just throw a brief light on that for us.
I think if any one of us, I mean, I'm sure all of us would have very patiently and very closely, if you've heard Dr. S.K. Rao's talk, I think it was a wonderful talk which covers up virtually everything. And after he speaks, I don't think anybody can add anything. I mean, it was so beautifully and simply put. And what I'd like to say is one thing is I believe strongly that the doxycycline and all those things really have a role when your lid has vascular issues, telangiectasias and those stuff. That's when your all your inflammation is very high. And apart from that, I think one the second aspect I would say is I don't know how many of you in the panel would agree there was a time when dry eye was, especially the evaporative dry eye, had a very clear distinction of inflammation was not inflammation. But in the cities where we are in, I would say that 99% of them are driven with inflammation.
Absolutely.
So there was a time we would wait for a year. We just used to come second or third time, and then think about starting them on restasis or cyclosporin drops. Now I'm in a stage where we start much earlier because once it reaches a stage, then even all these drops may not work. And I just want to ask the panel, Dr. Fogla and S.K.Rao sir, about this. Do you really believe in starting them early in your practice? Because Chennai, Hyderabad, Bangalore, and Delhi are all the same kind of a practice.
Go ahead, Rajesh.
I think it's important to look at it preoperatively. If you feel that preoperatively, if your patient has some element of meibomian gland dysfunction, you should institute therapy before the cataract surgery and continue post cataract surgery as well. Don't think that by doing the cataract surgery, your job is done and then you just give your routine medication and expect the patient to be happy with just using lubricants. One thing I have found is that sometimes after the cataract surgery, because you have the restrictions of not applying water to the eye for about a week,
Yes.
patients don't really clean their face. And then if you're using drops, which tend to precipitate or crust on the lid margin, it kind of worsens the pre-existing meibomian gland dysfunction. So that thing about cleaning the eyelashes and using a cotton bud and sterile way you do lid wipes, that has to be emphasized to the patient in the post-operative period.
I think that's a very valid point, Dr. Rajesh. I agree with you. Most of these patients, they have inbuilt notions of no water inside the eye or on the eye. And we, in my practice, on the seventh day onward, we tell them to have a complete wash, face wash, and eye wash. But I'm surprised that patients, even after 1 month, in spite of it being written in the discharge summary, and most of the patients who will complain of an irritation or a foreign body sensation or a dry eye would be the ones who actually, as you hit the nail on the head, have not put any water on their eye and the eyelid
Yeah, so
hygiene
that's
is
why
bad.
in the post-operative instructions, after a week, I usually recommend nighttime warm compress to the eye, at least for a month or two,
Mhm.
irrespective of the fact whether the patient has meibomian gland dysfunction or not. By doing that measure, they feel that you have given them some instruction which is simple to follow. And
Mhm.
even if they are not, cleaning, doing lid scrubs or anything, doing that warm compress at nighttime definitely has a regulatory effect on the meibomian glands and keeps it much functioning better than otherwise.
Yeah. Dr. Natasha, your comments?
I absolutely agree, and congratulations on the talk, Dr. Rao. It just summarized everything so well. If a PG student just listens to your talk and write an essay on
MGD.
MGD, it was so beautifully described. So congratulations on that.
Thank you.
And just to add to this, I think we're seeing the similar conditions in LASIK patients, just to take a leaf from cataract patients also. LASIK patients, especially the ones with flap, they tend to have, they just don't tend to touch their eyes because they feel the flap is going to get dislodged. So what we have also started doing is we try to assess for MGD beforehand. And if they have MGD, we treat them with either intense pulse light or lippy flow, and then take them up for LASIK. And this is something that I learned from Dr. Rohit when he had described this in one of his talks, and I found that the patient outcome was much better. In fact, their post-operative medications have also reduced. So I don't have to continue steroids for a very long time in such cases.
Yeah, I agree. You see, I got this idea from Rohit also. Whenever I have a patient whose borderline symptoms dry and is in for a refractive surgery, we take them up and make sure that the symptoms have actually disappeared, their OSDI scores are better, and then take them off for surgery. Because once the surgery happens, they will tend to blame the surgery and the surgeon, and
Absolutely.
the whole thing gets deflected. And the next thing you have is what I have with my cataract patients walking up to me. They will send their relatives for LASIK to somebody else and blame the surgeon. So I think that's a
Nam,
beautiful learning. There's a beautiful
and
learning. And this tip, again, I attended one of Rohit's sessions and I picked it up from him. I really follow what Rohit says. A lot of them are, sometimes they might sound very far out and very distant, what he says, but it comes up with a lot of amazing clinical and scientific experience and insights. So I guess this is a very, very interesting thing. So I guess